Give me a minute, sorry.
You have your customary set of chocolates packet.
Okay. So, good afternoon, guys. The topic, we have two topics of respiratory system today. Unfortunately, the first topic, which was ARDS, the presenter is busy on the ECU shift today, which we are going to reschedule for the next time. We're going to start with prone ventilation in ARDS patients. And then we're going to move on to the second topic, which is Banuja's topic, tracheostomy and laryngectomy. Okay, Anjana, are you ready?
Yeah.
Let's start now. Thank you.
Thank you. So I'm Dr. Anjana Rajan Babu. I just recently joined as registrar. This is a discussion about prone ventilation in ARDS patients. It is based on a review article which was published in the Intensive Care Medicine in 2020.
Hello.
Mic is on.
Can you hear me?
Yeah, now we can hear you.
Yeah. Okay. So prone ventilation in ARDS patients is the topic we are discussing today. So prone ventilation has been used now for many years in patients with severe or moderate to severe ARDS, receiving invasive mechanical ventilation with sedation and paralysis. So initially, even though many articles on prone ventilation has been coming in over the past 2 decades, it has picked up in use more recently as more and more evidence is coming showing the benefits of prone ventilation. So we might have seen in the ITU that when patients have refractory hypoxemia, in spite of a high FiO2 and high PEEP, that's when we make the decision to prone a patient. And once we prone the patient, in most patients, we see that the oxygen saturation level comes up. So what happens when you prone a patient? What happens? We'll go through each component of the respiratory system. So what happens to the chest wall compliance? So the chest wall is a structure composed of the spine, the ribs, and the abdominal boundary as well. So in supine position, the posterior chest and the abdomen are fixed, whereas in the anterior chest wall is the one that is mostly mobile. So when we are proning the patient, the posterior chest wall, which is less compliant, is the one that is not applied to the back of the bed. So in which case, this should be the one with more mobility. But the anterior chest wall is splintered by the bed. So in net effect is that the chest wall compliance reduces when you prone the patient. Okay, so overall there is a reduction in the chest wall compliance. So what happens to the lung compliance? And the lung compliance is actually, it is determined by how much of the lung is getting ventilated or open to ventilation, or it's able to get to move with ventilation. So here what happens in the prone position is whatever change in lung compliance happens primarily due to opening up of the new pulmonary units. So if this is what is expected, so the improved lung compliance actually offsets the decrease in the chest wall flexibility. So we have to keep an eye on the plateau pressure. The next is the ventilation perfusion ratio, the ventilation perfusion matching. So when you put the patient in prone position, the alveoli are more homogeneous. The ventilation of the alveoli is more homogeneous. And the distribution of perfusion, actually when you look at the distribution of perfusion, there is more perfusion in the dorsal aspect or the posterior aspect compared to the ventral aspect. And when a patient is supine, as you can see in this picture, so when a patient is supine, there are more hyperinflated alveoli in the anterior part. And whereas in the posterior part, where the perfusion or the red area is more, the alveoli are less ventilated. So when you prone the patient, there is a better distribution ventilation. So the ventilation perfusion mismatch becomes less. This leads to better oxygenation. What happens to the recruitability of the lung? So there has been in many articles we see the same picture, that is when a CT scan is taken for a patient who has ARDS in the prone position as well as the supine position, what was found was that there is more density in the dependent part. So whichever is the dependent part. So the more denser area, this is the less recruited area. So when the patient is supine, the dorsal aspect or the posterior aspect of the lung is more depth, or there is less ventilation or recruitability in the posterior aspect. But when the patient is put prone, again this is the anterior aspect of the lung which is more dense. So the posterior aspect is more well recruited. So it is not an equal phenomenon, as in the difference comes because the lung is considered to be a conical structure, or more mass of the lung is considered to be posterior. So if the posterior part of the lung is better aerated or better recruited, then more mass of the lung or more lung tissue is getting ventilated, because the anterior part of the lung, it is offset by the mediastinum, the heart. So the more lung volume or the more lung mass is in the posterior aspect. So this is what is recruited into the ventilation. So in effect, we have discussed all the other factors which determine how the oxygenation and the carbon dioxide elimination happens. So the oxygenation, the quantity of tissue which is open to ventilation and perfusion, the mismatch has the ventilation perfusion mismatch is less, so the oxygenation is better. The inflation, the homogeneity of inflation of the alveoli is improved. Okay, and there are regional changes in the chest wall compliance actually also may contribute to improvement of the oxygenation. What happens to the carbon dioxide elimination? So in the carbon dioxide elimination, it can happen either way according to this article. So a decreased PaCO2 can happen for the same minute ventilation, and this is because previously collapsed units are recruited into ventilation. Whereas in some cases we can see an increase in the PaCO2 because of the reduced chest wall compliance, because of increase in the pleural pressure or reduced venous return. It can result in a reduced CO2 elimination. The desired result that we seek is a decreased PaCO2. Now what happens to the hemodynamics? So various studies have reported different response in the hemodynamic response to proning. So but I feel if there is any difference in opinion or any valuable opinion based on practical experience, please share. So according to the APRONET study, in the APRONET study, which was one of the earlier studies. So most of the studies have considered a MAP of less than 65 as an exclusion criteria for proning. Even the ProSiva trial uh, has excluded people with a MAP of less than 65. But this also have shown such patients have shown a benefit um, in their oxygenation during proning. So it is also to be noted that initially, even though these patients had a MAP of more than 65, so many patients continued to have prone ventilation when the hemodynamic condition deteriorated. That is, when norepinephrine was started after later on. So one reason why this is um, taken as a criteria is that some studies have reported a hemodynamic instability when the patient is prone. So there are some studies which report that there is a reduced venous return due to the thoracopelvic supports, which impair the venous return, leading to reduced stroke volume and increased heart rate. But even then, there has been studies which report an improvement in the cardiac output because of right ventricular unloading. Also, in many cases, we'll see an improvement in hemodynamics because we are able to avoid high peeps because we get better oxygenation with the prone position. So in general, what are the indications? When do we consider proning in a patient? When we need to improve oxygenation. So this is especially in moderate to severe ARDS with a PaO2 FiO2 ratio of less than 150. And when the FiO2 used has to be more than 0.6. So in the early trials, even though there was an improvement in oxygenation, there was no reduction in mortality with proning. But later studies have proved that there is a reduction in the 90-day mortality by almost half in patients with a PaO2 FiO2 ratio of less than 150. So it is also now being advocated that as more and more studies are being done, that more studies should be done in moderate ARDS as well, and early rather than late proning is recommended, and it may be useful in mild to moderate ARDS as well, because there is less overdistension of the non-dependent lung and less cyclical airspace opening and closing, which prevents the ventilator induced lung injury. So there is a call for a recommendation that proning can be done even in moderate ARDS. So what are the contraindications? The only absolute contraindication according to this review article is an unstable fracture of the spine. But there are other related contraindications like hemodynamic instability, which is in spite of treatment with fluids or inotropes, any unstable pelvic fracture, long bone fracture, severe facial fractures, open wounds of the abdomen, increased intracranial pressure. But again, this is a relative contraindication because if we are monitoring the intracranial pressure continuously, we minimize obstruction to the cerebral venous drainage by adjusting the position of the patient. This also can be carried out. There are other things which are which were suggested as contraindications, but like rheumatoid arthritis with atlanto-occipital joint involvement. But even in such cases, proning can be considered if the patient has a rigid cervical collar. In massive obesity was initially considered as a contraindication, but this also has been questioned as these patients do benefit from prone ventilation. Mid to late term pregnancy again was considered initially as a contraindication, but it has been recommended that proning can be done with proper positioning to limit abdominal compression and with continuous monitoring of the fetus. So how do we implement the prone position? So I think most of us have seen how this is done. We have a proning checklist which we go through before we implement the prone position, but I will just go through in case, just for those who have not seen this. So what is recommended by the FICM is what I am giving now, the pictures that I'm giving now. So minimum of 5 people, including a doctor at the airway. There is a dedicated person needs to be there at the airway, and 2 people on either side. So the airway person is positioned at the head end, and he is the one who coordinates. So in case the patient has more lines or additional drains, we can call as many staff as needed for proning. So at first the patient is laid flat in the neutral position on a clean sheet, and a slide sheet is placed beneath the patient. And the arm closest to the ventilator is tucked under the buttock with the palm facing anteriorly. The anterior ECG electrodes are removed, and pillows as needed can be placed over the chest, the iliac crest, and the knees according to the patient's body habitus. And then a clean sheet is put on top of the patient, and as you can see from both sides, we wrap the patient tightly in the patient. So the patient is encased, and the pillows and the patient are together encased, and the head and neck of the patient only is remaining exposed. So with this, the patient is moved horizontally to the edge of the bed, and the first move, that is the first horizontal move, is away from the ventilator in the opposite direction to which the patient will be turned. So whichever side the ventilator is, that is the side to which the patient is being turned. So it is the turning is done in steps. First, a 90-degree turn to the lateral position, and then the changeover of hands from between the staff. That is, staff on either side should adjust their hand position on the rolled up sheet so that they hold the opposite edges. And on the call of the patient at the head of the person at the head end, the rolled up sheet is pulled up from beneath the patient, and patient is turned carefully into the prone position. So the head and neck is carefully supported, and the endotracheal tube is carefully supported so that it is not kinked. And we have to be sure that the length of ETT at the lips has to be reviewed, that it has not gone far in, and the monitoring is then re-established. So after the patient has been brought to the center of the bed and the slide sheet has been removed, we are checking all the lines of the patient, all the monitoring of the patient, and make sure that all the pressure points are well padded and there is no compression on the eye. And it is recommended that the position of the head and the arms should be rotated every 2 to 4 hours. So the swimmer's position is what they call it. The arms are put in the swimmer's position. That is, one arm is on the same side to which the head is facing, while the other arm is on the side of the patient. The shoulder abduction, 80-degree, elbow flexion at 90-degree on the raised arm. So a 30-degree reverse Trendelenburg position is given to nurse the patient, and we make sure that there is counter traction so the patient doesn't slip down. What about the ventilator settings? The ventilator settings are consistent with the recommendations for ARDS, that is a tidal volume of less than or equal to 6 ml per kg as per the predicted body weight, and reduced to the lowest values tolerated, and the PEEP is titrated to the optimum value. And this is re-evaluated and adjusted to be as protective as possible. And when we deprone the patient again, we have to re-evaluate because the patient may again decompensate, or the patient may not tolerate the supine position. So again, when the patient is deproned, again the same measures are followed. That is, we follow the checklist. There is an airway trained doctor. We pre-oxygenate. We secure all the lines. Any non-essential infusions are discontinued. Adequate sedation and muscle relaxation is given. The nasogastric feed is stopped all this is part of the checklist that we have in our ITU. And the patient wrapping and moving is done. So when do we do deprone the patient? One is an emergency deproning. So emergency deproning, we should always discuss when we will do it and when should emergency deproning be done. So when we do emergency deproning, we have to be careful because we should protect the patient from any dangers as well as protect the staff. That is, a lot of patient staff members also develop injuries, back pain, and all these problems when adequate staffing is not available. So turning a patient in an emergency without sufficient help risks further harm to both the patient and to the staff. So in case of a cardiac arrest, cardiac pulmonary resuscitation can be commenced in the prone position as well, the mid-thoracic level being the area of compression. And in case there is a dislodgement of the endotracheal tube, which is the other fear that we have, what happens if a prone position patient has a dislodgement of the endotracheal tube. So it may be initially managed by using a supraglottic airway device like an iGel, which gives a better control of the airway in an emergency. So this is a copy of the checklist that we have. I'll run through it quickly. Before the procedure, have all the members of the team introduce themselves. Is a consultant or a senior nurse aware? Are there any contraindications? Is re-intubation equipment available? Are the eyes taped and lubricated? Is the endotracheal tube taped or tied? NG feed aspirated? Non-essential monitoring and infusion discontinued, adequate length on the remaining lines going either up or down the bed rather than through the side. Chest drains below patient clamped only if it is safe to do so. Assess and document skin integrity, anti-pressure dressings, daily hygiene completed like mouth care, washing, equipment available as per guideline. Is there any concern about this procedure? So this is asked before the procedure. And a verbal confirmation between the team members is a timeout, minimum of 5 people plus 1 for chest drains. All team members aware of their role, appropriate ventilator settings, cardiovascular stability, adequate sedation, RAS of -5, adequate muscle relaxation, pillows being positioned correctly, chest, pelvis, knees. Team members familiar with how the procedure is going to be carried out. And after the procedure is done, again when we sign out, check for the endotracheal tube length at the teeth, check for capnography tracing, make sure that all monitoring is re-established and the patient is stable, review the ventilator settings, make sure the lines are secured, chest drains below the patient, and always check for pressure areas, endotracheal tube not pressing against the lips, no pressure on the eyes, ears are not bent over, there is no pressure by the NG tube, the penis is between the legs and catheter secured, and any line or tubing is not resting against the skin, pillow positioning, and then the slide sheet removed and reverse Trendelenburg of 30° given. NG tube position confirmed, post proning, care bundle, is this available, yes or no? So when do we stop the proning? That is the next thing. So it has been mentioned that longer the duration of proning, the greater the benefits. And improvement in when the improvement in oxygenation comes to a point where we feel that now we can use a ventilatory mode which allows the patient to breathe spontaneously, or assisted ventilation can be used, then we can consider discontinuing the proning. Or if there is a deterioration of the patient in the PaO2 by FiO2 ratio by more than 20%, or if there is any other life-threatening complication. So different articles have given different durations of proning, starting from 7 hours to 16 hours to 24 hours at a stretch. So when we prone, again, what are the adverse events that can happen? You all will be knowing this. Any displacement of any devices, accidental extubation, hemodynamic instability, vomiting can happen, loss of venous access can happen, positioning can cause brachial plexus injury, pressure ulcers, ocular, increase intraocular pressure, corneal abrasions. So all this is why it is important that the team which does the proning and deproning, they are trained and they know what they are doing. This also helps to avoid staff injury. So this is what I have put together, and please give in your inputs regarding uh, any more theoretical or practical experience that you have. Thank you so much for listening.
Thank you, Anjana. Anybody has any questions? That was a very practical, concise presentation. And you covered almost all the points. Very nicely done. Anybody who's got any comments, any questions, anything that you want to repeat? Yeah, Hamad?
Yeah. So it's a very good summary for the proning procedure that we are frequently using in ICU with ARDS and even other patients with severe hypoxia. I just want to comment that the indication for proning at the PO/FI2 ratio less than 150 in a patient who is given full sedation with a muscle relaxant and with therapeutic beat more than 10. Because we want to limit, because it's still a harmful procedure and patient may develop complications. So we want to make sure that he will benefit from the procedure. I just have one question. Can we prone a patient on a tracheostomy? And how challenging that will be?
Yes. Yes, it has been mentioned that a patient on tracheostomy can be prone, but it requires a special support for the head so that there is space, and also there is a mirror. This is what I read. I have not seen this. A mirror to be kept, which shows us the intact position of the tracheostomy, and adequate provision to suction the tracheostomy tube should also be put in place.
I think it's the prone view mirror that we use in theaters in routine.
Yeah, but basically we've got this gel frame and then you...
Yeah, but this is like a special setup for the tracheostomy patients in ICU. Anything else? Anybody else? Any questions? Any comments?
I'm not sure if I missed it. What is the minimum and the maximum time someone can be prone?
Can be prone. In our ICU, we use 16 hours, but it really depends on the patient and sometimes the consultant's decision. But usually it is 16 hours. But like she said, in different articles, it's mentioned up to 24 hours and less minimum limit up to 8 hours.
I got 36 said it last week.
Sorry?
I got an A1 and that's 36 hours.
36 hours. Yeah, but it comes with its complication and risk, especially the pressure areas are very bad in the patients. So we have to do properly the positioning and protect the areas. Anything else?
If you prone a patient, I know you're looking at if the PO2 and FI2 ratios improve. Is there basically a certain period of time it has to stay like that, or is it as soon as it's improving, you think it's better, it's time to deprone, you just deprone the patient? Does that make sense?
Sorry, no, I didn't get it. Can you repeat your question a bit louder?
Just before you're going to deprone the patient,
yeah.
Check your parameters. Okay, the PO2 has come above A, so the FI2 is coming down. Does that have to go on for a certain, like 1, 2, 3 hours, a certain period of time before you deprone the patient?
As in the improvements in the numbers,
I feel like
I think it's the entire picture of the patient, and usually these patients it's almost like second last resort, prone position, prone ventilation before you go and discuss about ECMO for the patient, and usually they are very bad and they have to be prone and deproned in between to just to be able to see if they improve or not. But they might not. And also
the lungs doesn't improve overnight.
Yeah, exactly.
It takes time. Even when you've prone a patient, it takes up to 6 to 8 hours to see a minimal change in them. So of course, it's the numbers which are more reflective at the end point. But then usually, from what I at least remember on our ITU, 16 hours, we kind of deprone them back. Even if they are improving, we deprone them, make sure that they have a proper regulation but to aerate the remaining part of the lungs. And then again, if there was no sustained improvement, we prone them back, just to give them additional benefit and see if that helps.
It's usually 16 hours proning, 8 hours deprone, and then again you make them prone for
24 hours basically. This is how the cycle runs.
Exactly. All right, guys. Anything else? Anybody else? Any questions?
Is it mandatory to check like through X-ray or anything the tube position when we prone and deprone?
Ideally, you would look at the lip
Protein,
margin
I
wherever
don't
the
think we
trial
do it.
was done, and
Yeah.
if you're happy, because you will always auscultate the patient,
Take
what
all the
you're looking
numbers.
at the ETCO2 to see if everything else is there. If you're happy with the ventilatory curves, the ETCO2, I don't think we're doing that.
Yeah, and when the patient is prone, we don't do X-ray.
Don't do
Just,
X-ray.
yeah, wait till they are deep prone
If
and.
you put a new tube or central line, please make sure to take an X-ray before we attempt prone.
Before that.
Otherwise, you cannot.
All right, perfect. So we'll move on to the next presentation. Banuja.
Thank you very much, Anjana.
Yeah,
Thank
just
you.
Thank you, Anjana. It was lovely.
name of the-
How do I stop screen sharing?
Yep. Thank you.
Hi guys, can you see my screen?
No.
Oh.
Anjana, if you can stop your slide share.
Can you see my screen now?
No, can you share it now? Like redo it, the entire thing.
Okay, I will try to do that. Can you see it now?
Yeah.
Okay, fine. So my name is Barney, I'm one of the F2s, and I'm just going to do a very quick recap about tracheostomies and some certain red flags to be aware of and what you would do in kind of an emergency situation to do with tracheostomies. So just a tracheostomy is basically just an opening into the cervical trachea, which is created through either a surgical incision. And here are some certain indications of when we would use a tracheostomy. In acute upper airway obstructions, edema or foreign body, you would use a tracheostomy. For prolonged artificial ventilation, so with prolonged endotracheal intubation, there's a high risk of damage to the soft tissues of the mouth, the pharynx, and the trachea. It also reduces the patient's ability to communicate and also increases work of breathing by extending the dead space. So a tracheostomy kind of reduces all of that. So it reduces the damage to the mouth, pharynx, trachea. It shortens the amount of dead space. So there's actually a decreased work of breathing, and it increases the chance of communication between you and the patient. And because of the shortening of the dead space, it also allows us to wean a patient off artificial ventilation, which is why it's good too. Also, if a patient is unable to maintain their own airway independently, for example, if they have a reduced cranial nerve function, brainstem damage, or just poor conscious levels, so they're unable to protect themselves from respiration. Another one is just bronchial secretion. So, for example, if a patient has a poor cough and they can't clear their bronchial secretions, that would be a reason to consider tracheostomy. And also surgery to around the upper airway. You see this in ENT max fax patients. We also have laryngectomy, so I'll briefly touch on this. So laryngectomy is when you remove all the laryngeal structures in the epiglottis and part of the upper trachea, and then the trachea is brought to the front of the neck to create a stoma. So with a laryngectomy, you have no connection from the mouth or the nose to the lungs. So your traditional ways of airway manipulation wouldn't work. So reasons why you would use this, the main indication would be advanced laryngeal cancer, but also in kind of severe neck traumas or severe irreversible aspiration. Those are indications for why you would use a laryngectomy. Just going into what a tracheostomy tube looks like. So here's a picture for you. So you have the inner tube and the outer tube. So the inner tube is slightly smaller than the tracheal tube itself. It fits inside. This is good because it can be easily removed or replaced, and you'd want to do this if you were trying to remove secretions or even treat an obstruction. Then you have the cuff. So that's to secure the airway. So you have to, so once the airway is in the correct position, you would inflate the cuff, and you'd have to monitor the pressure of the cuff to ensure that there aren't any leaks. But also another risk is overinflation, because it can cause damage to the tracheal walls at the same time. And then you have the flange, I think that's how you say it, but it's just secured to the skin by sutures or even tape, for example, in ENT patients. And that can be adjustable or non-adjustable. Stoma care, so very important to take care of an opening, I guess, for obvious reasons. So the main thing is obviously infection control, so that's very important. Dressing changes, because you can get quite a lot of secretions above the cuff itself, which can ooze out into the stoma, which can obviously cause infections and also just skin irritation. You can do suctioning of the inner tube. So you would do this when you have visible or audible secretions. You have desaturations or increased coughing in the patient, or even absent breath sounds, and also just to maintain the patency of the tube itself. And then also maintaining oral hygiene. You obviously do this with chlorhexidine, mouthwash and gel in ITU. Can change the inner tube, which should be done, and also humidification. So the tracheostomy bypasses our own body's humidification system. So the secretions that someone with a tracheostomy may have would be drier and also therefore harder to remove. So you'd have to, well, you could use saline nebs to kind of counteract that. So red flags, so things to just be aware of with a patient who has a tracheostomy. So first one, airway. So if a tracheostomy is cuffed, the patient shouldn't actually be able to speak, because no gas should be able to escape through the mouth. So if they're talking and there's an audible air leak, or there's bubbles of saliva that you can see coming out of the nose, the mouth, then gas is obviously escaping from the cuff, which indicates that either the cuff is damaged or the tube or the tip is displaced. And obviously, if you hear grunting, snoring, stridor, those are obvious indications of airway problems too. Second one is breathing. So is the patient breathing? Are they having any difficulty breathing? Those would be two things to obviously look out for in a patient, which you would do in any. And then more specific to having a tracheostomy, can you see that the tube is visibly displaced? Can you see blood or blood-stained secretions around the tube? Is the patient having any discomfort or pain? And also, is there a lot of pressure, a lot of air that's required to keep the cuff inflated? Because if you have a damaged cuff or a tube that's displaced, the cuff would, so if you have a damaged cuff, you're going to need more air. And if you have a tube that's displaced, the cuff will need to be hyperinflated to actually keep the cuff sealed. So that could be, that would be a red flag too. So in terms of now what to do when you see a red flag, there was a video I wanted to show you. So tracheostomy.org has some really great guidelines for kind of recognizing emergencies and what to do in these emergencies. Would I be able to show you the video? It's like 2 minutes, or I can just talk you through it.
Yeah, you can share the video.
Okay, fine. I will. Can you still see my screen?
We can, yes.
Okay, fine. So I'll just play the video on here.
Yeah. 46. We can still see the same slide with the link on it.
Oh, you can't see the video?
No.
Oh, okay. Can I, the link is actually on the presentation.
Is it the second one or the first one?
Ooh, let me just have a look again. I think it's the first one.
The first one is the algorithm, isn't it?
Okay, sorry, it's the second link, yeah.
This PDF.
PDF file.
Does it work?
It's a PDF file which says algorithm. One of them is probably this tracheostomy bundle, isn't it?
Yeah, so okay, I'll put the link up later, and when I give you the presentation, I'll just talk through the algorithm then and just tell you what to expect and what to do. Is that okay?
Should I be, I can share the algorithm. Let me just share the algorithm.
Yeah.
Is it this one? Can you see it?
Exactly, that's the one. So
Yeah.
we'll just talk through this then. So I'm just gonna very quickly go through it. So first of all, obviously, is the patient breathing? Are they not breathing? If they're not breathing and there's no signs for life, put out a cardiac arrest call. If they are breathing, then, apply high flow oxygen to the face and the tracheostomy. And then you have to start assessing the patency of the tracheostomy itself. So you can start by removing the speaking valve or the cap, and also remove the inner tube, which we were talking about before. And if you can then pass a suction catheter through that, then suction it, and it means that the tube is patent. So you can then ventilate through the tracheostomy itself. If you can't pass the suction catheter through the tube, the next step would then be to deflate the cuff. So give it a look, listen and a feel. And then if you find that the patient is improving, that's good. It means that there was probably a partial obstruction of the tube, or the tube is displaced. If the patient was not improving, is not improving and is not stable still, then remove the tracheostomy tube itself. Ensure that the oxygen is supplied to the face and the stoma, and then kind of reassess. So again, is the patient breathing? Yes or no. If they're not breathing, again, put out cardiac arrest call. Then your next step, if the patient is still not breathing after that, would be emergency oxygenation. So this can be gone down the route of either primary or secondary. So primary would be either through an oral airway or the tracheostomy itself. So oral airway, make sure to cover the stoma, obviously, because otherwise the air is going to escape, however you ventilate. You can use a bag valve mask, or oronasal adjuncts, or a laryngeal mask as well. Or if you want to go through the tracheostomy and ventilate through there, you can use a pediatric face mask and ventilate the stoma itself, or again, a laryngeal mask and ventilate the stoma itself. If you can do secondary intubation, that would obviously mean to intubate either orally or through the stoma. So that's kind of what this guideline is. There's also a guideline for the laryngectomy, which I haven't put up there, but it's kind of it's pretty much a similar concept. But I will link them all in the presentation that I'll upload. Yeah, that's my presentation, very quick. Do you guys have any questions or want to make any comments or anything?
Thank you so much. That was very brief and good. Any questions, guys? This algorithm that she has shared, this is a very important one which comes up in exams, and even in real scenario, if you have a patient that you're worried about that the tracheostomy is it's working, it's not working. So what I do is I use an algorithm which is, sorry, I'm just going to try if it works. It says O 6 O. Okay, so we start whenever you get a patient that you're worried about, that patient has the tracheostomy is working or not in your call, you go and you start with your ABCD assessment. Okay, so first O is for oxygenation. You first of all go and do your assessment and put the oxygenation through the mask as well as through the stoma. Okay. Second one is capnography. Always make sure that your capnograph is there, if the trace is there or not. It will give you a hint that is it entirely displaced, is it partially displaced, is there something going in or not at all, it's totally blocked. Okay. And then I is inner cannula. So first of all, you try and take out the inner cannula and see if the patient is still breathing or just struggling to breathe or not at all. And then you would try and pass down your suction catheter. And if it's not passing down, then obviously it's totally blocked. But if you can do the suction, then you have a hint that I'll be able to oxygenate and ventilate this patient. And then is the cuff down. So you bring the cuff down as a last resort before you look for other options, which are going to be to intubate, or you just take the tracheostomy out and ask for help and re-intubate through another route. So then you're going to be looking at other options. So I feel like this is a thing that quickly comes in your mind if you go into an emergency scenario, you call and because the algorithm that she shared is amazing, it's great, but it's just a bit busy slide, and I just feel like it's
For the first two again, sorry, oxygen.
oxygenation, capnography, inner cannula, suction, cuff down, and look for other options. You have to have another plan.
After the cuff down, you will first change the trachea and then try to intubate from the mouth.
The cuff down and see if you are able to oxygenate the patient or not at all.
Okay, would you change the trachea tube?
You would not. You ideally need to ask for an expert, and you should have a senior by your side always.
Would they change the trachea tube?
So usually if the trachea is blocked, with cuff down, you'll be able to, the patient will be able to breathe
Yeah.
through the
Okay.
catheter.
So this would be an indication that it was blocked.
Yeah.
The trachea tube.
And again, it's like if it's 7 days, usually, then the track is well formed, and you are able to change it. But if it is before 7 days, the track is not well formed for the tracheostomy, and it's a bit more risky. You can bring the patient a lot of complications, subcutaneous emphysema, false tract formation, all of those things can happen. So before 7 days, it's not recommended that you change it by yourself. I hope that's useful. Guys, any other questions, comments? Let's stop sharing this somehow. So last bit is about.
Just one comment. Any idea how to decannulate the tracheostomy?
How to decannulate?
Yes. And once a patient is now ready, I can close the trachea. Because this is what we see usually. We put the trachea. But you need to know how to decannulate.
I think it's the part that physiotherapy take over, and they do it. They make sure that the patient is ready and can.
So it's good cough, less secretion, and basically he doesn't have cranial nerve problems or bulbar palsy or GCS is okay. And you train with, you block the trachea and you let them breathe by the mouth, you deflate the cannula, and yeah, then you can say that the patient can be able to be cannulated.
Yeah. Sure. So any other guys comments? The people who are on MS Teams, any comments or questions? Anything you want to share?
Surely, like how many days after intubation we consider for the tracheostomy? Is
It's
this
highly variable. Honestly, there are no proper guidelines
There's no
anywhere. It really depends on consultant decision as well as what the patient's overall condition is. If you feel like the patient is going to be ventilated and is going to be there for long, then we usually opt for tracheostomy. 10 to 15 days. Hello? Okay. Guys, please fill up the feedback form because your feedback is very important. It helps us improve whatever we are trying to do for you here. I'll share the QR code. Please fill up the feedback form. I don't think the people on MSC are able to see this.
Wow, you did one and done it. Oh, wow. Yeah.
Thank you. Thank you, guys. See you next week with a new topic. I hope you've all marked your attendance.
Guys, have you marked your attendance?
Yes.
Thank you. Thanks. Thank you.
Thank you. Okay, yeah. 16th
On the night shift in March.
16th of March.
I
You're in
can
March.
try it.
As in
I
on
do the last
16th or
16th, 1/6 of March.
are you on night on 16th or 15th?
All 3 days.
All
So
3
I'm
days.
on nights like Tuesday, Wednesday, and Thursday. So I just Wednesday night I'll be finishing, going home, sleeping. I can do it if I'm the last person.
I can make you the last one.
Yeah, that way. If I
But
wake
if you
up,
feel like you are absolutely shattered and you cannot do it, just start it with someone.
I'm trying to find some
in time.
slots. I'll see if I can. Do we swap the topics as well?
Yeah, just swap the entire thing.
I'll try to find out. Thank you.
Thank you so much.
Thank you so much.
Thank you.